This video will look at shoulder, referred pain and local pain, generalized pain around shoulder and point pain. And we'll look at the causes and the identification of the pathology present. This is a sort of general initial approach to shoulder pain. You can consider it as either referred or local, and they're really your two choices, although you can have a mixture of referred and local pain of the shoulder. So the defining characteristic that differentiates them is really on function. From patient's history, is it activity and function of the shoulder that's painful, or is it the posturing of the neck? Is it visceral function? Is it shortness of breath that accompanies this, and so on? So this is your main differentiator. What actually produces the pain? What behaviors? Objectively, this is much easier, actually. You can move the arm, and if you're not reproducing shoulder pain with large range passive and active movements, then basically you can say the shoulder is not affected and it's not coming from the shoulder. So movement, active and passive movements over a large range, should be very sensitive for local pain. On the other hand, moving the neck around because you think that this may be the source of the pain doesn't work as well, because simply moving the neck rarely causes shoulder pain at the time you're moving it. It's much more likely that after you've examined the neck and shifted it around, the patient will experience the pain hours later sometimes, but certainly after you've finished moving it around. So the connection between moving the area that's causing referred pain to an area and local pain to an area is a delay. So this is your main thing. Also, you've got other factors, of course. With cardiac pain, you can be looking at systemic effects, sweating, shortness of breath, palpitations, and all the other things that go along with it. And visceral pain, if it's the organ, you're likely to get viscerogenic type pain, which is that diffuse, dull, heavy pain that just gets worse and worse and worse. The real problem here lays between when you have spondylogenic pain and local pain. When these two things are combined, now moving the arm is going to cause pain in the shoulder because you have a local tissue. So trying to figure exactly how much each is contributing to shoulder pain is a bit difficult. It's also worth noting that if I'm getting referred pain anywhere, actually, there's almost always going to be local pain at the source, and usually, very usually, a topographical link between the two areas, pain spreading from one and going into the other. Isolated pain in the referral area is can happen, but it's not very common at all. Okay, so let's look at point pain first. Typically, the point pain will be up on the anterolateral area of the shoulder and sometimes superiorly, but this sort of area. And it's usually quite a sharp, distinct pain as opposed to the more achy pain of the diffuse referral that you get from a shoulder arthropathy, for example. Now, the main things that's going to cause point pain are tendinopathies, AC joint dysfunctions, labral tears, and bursitis. So let's look at some way of rationalizing how we can approach figuring out which of these things it is. Well, if you palpate a tendinopathy, then it's going to be tender. Provided you can reach the entire tendon, then you're going to produce tenderness when you palpate for it. Now, while you can't palpate all of the tendons, a lot of it's underneath the acromion, but the most important points where the tendon tends to get in trouble is at its attachment or near the attachment in the body. Most of this stuff you can reach. So it's going to be unusual when you can't palpate for tenderness in the tendon. Similarly with the AC joint, if this is inflamed or dysfunctional, then that's going to be tendon palpation as well. So we can palpate these as your screening test, basically. If it's not tender, you move on to the next tissue. The labrum, though, is not reachable by palpation, and certainly not easily reachable, and you're palpating so deep through so much stuff, you can't be sure that what's producing the pain actually is the labrum. So you have to go straight to testing. The bursa is going to be tender, provided you can reach it all. But again, this is really a diagnosis of exclusion, or it should be. So you're going to leave it till last anyway. Plus the fact if you're palpating for the bursitis and you've got no other tests to back it up, you have to eliminate the other tissues before you know that your palpation is actually producing pain from the tissue you think it's coming from. So it makes sense to pick something that's easily palpable as your hypothesis, your first hypothesis. And that is either a tendinopathy or it's the AC joint. We'll pick one, I'll pick tendinopathy for no good reason. But we start with palpation. And if it's tender, it strengthens a hypothesis. We can now do the contractile tests. If this is a tendinosis, which point pain is likely to be a tendinosis rather than tendinitis, one or other of the contractile tests will probably be positive. It's unlikely that both of them will. And most likely it will be the contractile tests. All the other stuff is sort of like empty can tests and all this other stuff. There's so much getting affected there. This is not particularly specific tests. So, but the contractile tests plus the palpation actually become fairly specific for the tendon, at least in my view. So if the contractile tests are positive, after you have a tenderness on palpation of the tendon, then our H1 becomes a diagnosis, at least a working diagnosis. If palpation on the tender is not tender, we can move to H2, which is going to be the AC joint dysfunction. And the joint line of the AC joint is easy enough to palpate. Now, you can't get to the underside of it, but usually you won't need to. So we can palpate it. If that's tender, we can then move into, with strength on H2, we can then move into pain provocation tests. The big one, of course, is cross-arm adduction. But the joint is likely to be painful at the extremes of at least two ranges, if not more. So we can go through full range of motion, see what's happening on these. And we can also actually grind the joint surface. We can grab the clavicle and we can grab the acromion. We can grind these on each other, up and down, backwards and forwards, and see if we can reproduce that pain. If it can, be fairly sure that the diagnosis is AC joint dysfunction. If the AC joint is not tender, then we move on to H3, which is going to be the labrum tear. And we've got two tests for this, O'Brien's and load shift test. O'Brien's works fine, actually, if it's done the way O'Brien pictures it in his photographs and not the way he describes it, it works fine. So what you do, the arm has to be medially rotated at the shoulder, not just pronated at the forearm. So this is a pain reproduction test. The load shift test is looking for a clunk, maybe with pain. Now, my opinion is you need both of these to be positive for you to say that the labral tear is actually the source of the pain. Now, if only the load shift test is positive and not O'Brien's, and there is just a clunk you get with this, not the pain, you certainly may well have a labral tear. But is the labral tear the source of the pain? There's no evidence for that at all. Similarly, if O'Brien's test is only positive and the load shift test is negative, then this could be coming from a different tissue. That test actually does test biceps long head tendon, and also, especially when you're doing medial and lateral rotation at the shoulder, where you're supposed to do pronation supination, but if you do it the way he pictures it, then you're also testing the transverse humeral ligament, and that can be your problem as well. So these two need a proper looking at if only O'Brien's test is positive. But don't forget where we are here. We know that the biceps long head isn't tender, at least as much as we can palpate it. But it still leaves us with the transverse humeral test. And this is the big thing about doing this in order, in some form of order, where you eliminate stuff as you go into it. If they're both positive, then we can say with some degree of certainty that this is actually a labral tear. If only the load shift test is positive, or if neither of these tests are positive, then we need to start thinking about the bursa. And we try to palpate the bursa. Now, some of these are very deep, and we need to palpate deeply to get them. But you've already eliminated most of the other stuff you're going to palpate through. So now that palpation is more specific for the bursa. You may be able to see the bursa swelling, particularly if it's one of the superficial ones, the cutaneous bursa or just subacromial, you may be able to see that swelling. If it's really swollen, then you can actually palpate it through the deltoid. But it's not always as simple as I'm making it sound. So, but you do have to palpate to see if it's tender. If it's not tender, then you're running out of ideas, or at least I am. So the thing is to see what you've done in the exam, what you may have missed, review the exam, redo the exam, or give it to somebody else to have another look at for a second opinion. Let's have a look at these point pain causes in a little more detail. Labral tears. From the patient, you may get a history of clicking or clunking. You may not. Usually you do at some point. Now, we're talking about degenerative tears here, not macroscopic tears. These are fairly obvious later, but at the time of the trauma, there's such a generalized traumatic arthritis that clinically it's going to be very difficult to tell which of these tissues is actually damaged. But if we're looking at these degenerative type tears, you don't get that sort of effusion. So clicking, you've got near full range of motion. Now, you've got to be careful with testing this range of motion, because what you can get is a small impingement of one of the fragments of the labrum. And what you'll find it will stop is elevation, and you'll just be missing the last bit of it. But you have to really stabilize the scapula to get this. Otherwise, everything's lost in the generalized movements. But if you stabilize the scapula, feel that, stop that from dropping down, then test elevation, you'll see the difference when it is jammed up. And this is manipulable. Otherwise, you've got full range of motion. No tenderness, except for a generalized tenderness around the shoulder because of possibility of segmental facilitation, but there's no focal tenderness there. And the labral test will be positive. Tendinopathies. Tendinosis is going to give you point pain. Tendinitis is much more likely to give you a generalized pain. So with tendinosis, you're going to see full range of motion and no pain at the extremes, generally speaking. Now, on the way of doing these full range of motion, you may see a deviation in the movement. You may see a painful arc. They're both actually painful arcs. The patient will deviate around it. And when you do a passive movement, you can get around the area as well by deviating and going up further, but you'll end up with full range almost always. One or other of the contractile tests, it will be positive. Tendinitis, this is an inflammatory condition that's extremely painful. You're likely to see a generalized pain around the shoulder. Actively, you will see often very seriously limited range of motion because of the pain. Passive movements, if you're careful and move it around the tendon, you can get pretty much full range of motion. But at least one of these pain will be painful on the extreme range because you're stretching that tendon. You'll see that both contractile tests now are likely to be painful, both stretching and the isometrics. And you shouldn't need much force with the isometrics. And this goes along with exquisite tenderness on palpation. You won't have to look for this tenderness. You'll just have to put your finger near it and it'll hurt. AC joint dysfunctions. If this is an inflamed joint, post-traumatic, it's a big one. But if this is an inflamed joint, then you're going to find generalized area over the top of the shoulder. So you're going to see this pain across there, and it'll be much more general than the point pain we're talking about. If it's dysfunctional, though, they're likely to put the fingers right on top and say, here it is there. And you're going to find the ends of ranges, at least two of these movements, you're going to get pain from as you push it, overpress it. Cross-arm adduction is actually quite sensitive, I think, for this problem. And there'll be tenderness over the joint line. Bursitis, if this is very inflamed, you'll see swelling. If not, you may not. But you can usually palpate some swelling there. It's going to be tender over the bursa, and you'll generally get full range of motion, again, if you're careful. But these can produce painful arcs as well. So if you move around it, you'll get the end of range, but you've got to deviate as you do it. Actively, they may not have full range of motion, and this may be a real issue for them. And in fact, even with an acute subdeltoid bursitis, which is among the most painful things I've ever seen in a patient. Don't see them in North America, you see them in Britain. You had an empty airfield with it. So even there, you had full range of motion. You just chose not to go into that range because it was so painful and disturbing. Also remember that the bursitis diagnosis is made when other conditions have been excluded during your clinical exam. Okay, so generalized pain, this is the one where it goes into the deltoid and go all the way down the arm. It can even go into the hand if it's bad enough, but certainly this whole area, and it may spread across the back and to the scapular and across the chest. Beware of the ones that are spreading. This may be something like a cardiac problem. Talking about cardiac problems, this can affect either shoulder, and it can affect both, but there's generally some radiation into the chest area. So look for the other stuff here. Look for changes in blood pressure, pulse rates, breathing, shortness of breath, sweating, and so on. So this is your major issue. Try to get rid of the idea that it's the cardiac problem. And then we've got visceral referral, which we discussed earlier. Now, tendonitis can give you generalized pain. We talked about that last time, in which case you're going to see all of the stuff we talked about previously. This is exponentially worse than a tendinosis. Bursitis, an acute bursitis can limit range of motion. I've seen these things where you've got a lump sitting up there like a golf ball, and it's not particularly painful tender on palpation. It's like the olecranon bursitis. You can press on these all day long, and it's not particularly tender. Often these people will come in because it's a lump and they want to get rid of it rather than painful. If they're not getting pain, you're probably not going to generate the pain either. Otherwise, bursitis can be extremely painful on palpation. Now, on to the other stuff, the non-referred stuff, the non-minor stuff. So we got arthritis. This could be systemic, and rheumatoid is a big one. Ankylosing spondylitis can do this as well. There's a few different arthritis that can do this, and it often affects both shoulders at the same time. But sometimes, particularly in the early stages, well before it gets diagnosed, it may affect one shoulder. So what you're going to see is moderate to severe limitation of range of motion. If you're careful with this, you might see it goes according to Cyriax's capsular pattern. That is most limitation of lateral rotation, then abduction, and least limitation of medial rotation. Cyriax never talked about flexion and extension, but if you do these right, they're going to be limited as well. It's going to be irritable and not a happy joint at all. If it's systemic, then you're going to likely you must ask for other joints, other tissues. Is it related to tendonitis and bursitis and so on? Osteoarthritis is a little rare in the shoulder, and it's anything from moderate to severe. Often it's very severe. Then it's going to be severely limited range of motion. Crepitus is going to be involved in this, and every now and then it's going to flare up. So you're going to be this episodic history of quiet and then a flare up. And this is going to give you an osteoarthritis rather than the arthrosis. Diabetic arthropathy is going to look like systemic arthritis. So if you have a patient with an unexplained arthritis anywhere, actually, it should be diagnosed correctly. If you can't do it in your clinic, and this isn't just about, I suppose it's osteoarthritis. This is not what we're talking about being correctly diagnosed. It's a positive identification of this, not I suppose it must be. If you don't know what it is, get it out and get it to the physician if it hasn't been seen by him already. Capsulopathy, which isn't an arthritis, but a primary problem with the capsule, looks the same as an arthritis, at least superficially when you see it. But these things tend to occur in three stages. They tend to occur in middle-aged women more than anybody else, and they tend to occur with 3 equal stages of severity or progress. So the first stage is where it's getting worse and worse and worse. This is the so-called freezing stage. Then it levels off and plateaus, which will be the frozen stage, and then it would become improving, which is the thawing stage. And they'll run 3, 6, 12 months, or 6, 12, 18 months. Generally speaking, at the end of the period, either it's 9 months or 18 months usually, the shoulder's in pretty good shape. Be careful with these. You want to treat them reasonably gently, especially in the freezing state. So probably the most effective treatment I've seen is electrotherapy, something that I have seen to try and reduce the inflammatory effects in the freezing stage. Strong Faradism, or muscle stim, but actually muscle stimulation to deal with the pain, and then also distraction, manual therapy, mild distraction. Don't hurt the shoulder during this stage, and you can shorten that stage right down. And then the last one we need to talk about here is a fracture, and this is going to be the same as any other fracture. You're going to find that there is a trauma, sudden onset as the severest pain. If the severest pain isn't too terrible, it's probably a pathological fracture. If it's very bad, you're not going to see them anyway because they're likely to go to the emergency room. So it's not one you're likely to see, but it's possible you may see a pathological fracture. Or we can include here a dislocation, a partial or a complete dislocation. The patient comes to see you instead of the emergency room. That combination of immediate onset of severest pain, get it to the emergency room, it should have gone there anyway. Okay, shoulder. The shoulder is one of the more difficult joints to assess. And in part, this is because there's usually multiple pathologies involved in this, because everything's so interdependent on the shoulder. And also, there is no inherent inert stability here. The whole thing is held together by muscle. So, for example, if I have a degenerate labrum tear, then you're going to have instability in the joint. And then you can then get the rotator cuff in particular overworking, or biceps overworking to try and stabilize the joint, and that can lead to a tendinosis down the line. So this is part of your problem. Don't stop at the first positive, okay? Even if you find there's a tendinopathy, keep going on that flow chart we looked at. Just go around and finish it off, because there may well be other pathologies present. Not the easiest joint in the world, but it can be, when you get it right, it can be very satisfying.